This week on the BackTable Podcast.
I don't want you to live your life in fear because you have done everything in your power to be cancer-free, and I'm doing everything in my power to give you opportunities so we can stay cancer-free. And trying to prevent brain metastases or recurrence with a brain lesion is something that I know I personally carry, that I share with patients, but I don't want them to live their life in fear of it. But at the same time, it's part of how the conversation is the successful use for Neratinib, saying that there's a lot in our futures we can't control, but that which we can, and that which we can try to do.
Welcome, everyone, to the BackTable Podcast. I am Lindsay Peterson, an associate professor of medicine and breast medical oncologist at WashU Medicine and Siteman Cancer Center in St. Louis, Missouri. Today, we have the privilege of talking with Dr. Jessica Trevino Jones at the UT Health Science Center in San Antonio. We're going to discuss precision medicine and biomarkers in breast cancer. So, Dr. Trevino Jones, welcome. Thank you for being with us.
Great. Thank you, Lindsay. It's a pleasure to be here today.
Yeah. So we were just talking before we started about how we didn't overlap. We actually just missed each other by a year. So you finished medical school at San Antonio when I finished my fellowship in San Antonio.
That it just goes to show that San Antonio makes great breast oncologists, am I right?
Absolutely. Absolutely. So yeah, I love going there every year for the breast cancer symposium, seeing all of the old folks. It's really great. So tell us a little bit about yourself, your role in San Antonio.
Yeah, well, it's a pleasure to be here. My name is Jessica Trevino Jones, and I'm an associate professor here in our Division of Hematology Oncology at Mays Cancer Center, UT Health San Antonio. I'm also the director of our cancer genetics program and the director of our prevention program when I'm not seeing breast oncology patients. And so I'm thrilled to be in San Antonio, having started Houston's first program and now getting to work here in San Antonio with this prevention program as well as breast cancer patients.
Yeah, that's wonderful. So where in your career path did you decide this was something you wanted to focus on, would you say?
You know, whenever we are going through medical school and whenever we're going through residency, there's a lot of pressure, right? Don't you feel like there's a lot of pressure to make up your mind and make this decision?
Absolutely.
And, figure out what research you're going to do and build this CV. And honestly, as I'm a first generation doctor, I'm a first generation college graduate. And so I really feel like a lot of my training, I was just trying to figure out how to just go from point A to point B. And it was actually during that time when I was overwhelmed with the whole just medical system and just trying to figure out what this career I signed up for is. And I realized that on those long days, the only time that I wasn't tired, and we were tired, Lindsay, right? Those were long days with a lot of duty hours.
Tell me how and when you weren't tired,
that, right? But it was the patient who had cancer. It was the person who was there with this disease that they had no control over. And I found that my energy, I could pull it from places deep that I didn't know, but that's exactly what they saw when they picked me to be a doctor. And that's how I knew I found my calling, was to work with cancer patients. And then very quickly after, I got plugged in with being a student in San Antonio with Dr. Kate Lathrop and Dr. Anand Karnad. And
yes,
the rest is history. The rest is history.
Yeah, that's great. That reminds me, I don't know who said this. Gosh, it might have been Dr. Karnad, to be honest, but he called it the 5:00 Friday consult. So you're walking out of the hospital on Friday, you have the weekend off, you get called on a consult. What type of patient, are you going to be, least frustrated about having to go back and see? And I agree. For me, it was always the same. I love seeing the oncology patients for many of the reasons you just said. So, okay, let's dive in. So precision medicine and biomarkers in breast cancer is a huge topic. Independently, they're huge topics. Within early stage, metastatic. So tell me, where do you want to start with this? Because we can take this in a lot of directions.
I think the best place to start, we really should talk about the metastatic setting and how this really changed just our treatment landscape. It in a few short years, we have seen not only the advancement and the rapid approval of so many drugs, so many life-saving, life-prolonging therapies, but knowing too that we're doing it at a level because of precision medicine, we have so much confidence. So I think we should start there. I think we should go with our metastatic setting.
Yeah, I think that makes perfect sense. You know, I find myself saying all the time, these drugs were not available when I was training. I say this to patients, right? A lot of time in the context of, trying to give some hope about all the treatments that are there. And by the time you need the next treatment, there may be a new treatment available. So that's such a good point. We have so many more drugs in our arsenal than we used to. So let's maybe talk about genomic testing. Let's talk about, when you're ordering genomic testing on your metastatic patients, what you're looking for. And of course, this is going to vary by subtype too, right? So maybe we'll start with our ER positive, HER2 negative patients. So for those patients, when are you doing genomic testing and what are you looking for?
When I look at our patient, we look at this woman, and for the sake of this conversation, I think it's safe for us to say women, and even though we know men can get breast cancer as well. But when I look at a woman, I like to first look and say, is this a cancer that you treated X amount of years ago and is now returned? Or is this a cancer that we only found in this metastatic setting? And so when there is a woman who didn't know she had breast cancer and she only finds out that, yes, I have metastatic breast cancer and yes, it has estrogen on it and it does not have HER2, I normally do not get genomic testing right away, right off the bat. I would say that I really like to do an earlier testing for the women that have been exposed to adjuvant hormonal therapies, that have been taking their tamoxifens, that took their anastrozole, especially if they were taking it and the cancer came back, right? Whenever they're on the drug.
Right. Those more early recurrences.
And I find that whenever we do learn about these different mutations, and specifically in this group of women, what I'm thinking about is a PIK3CA mutation, or I'm thinking about ESR1. I'm thinking about, hey, let's have this conversation about your different therapy options and what these different choices are, knowing that, there's lots of correct choices. There's not necessarily a wrong choice, but knowing these different mutations, we can guide our therapies, we can change up our medicines so we have a longer lasting benefit to the different drugs. And for a woman that has hormone positive breast cancer, I hope you agree, we can offer her so much time before getting chemotherapies, which is what most people think. Whenever you think of cancer, you think of, hair loss and vomiting. And I am so grateful that because of precision medicine and we can pick some of these targets, some of these drugs, and allow her to live a life where we can prevent that for her, give her some oral therapies as much as we can. So
true. Yeah, completely agree. I think that's the first thing I try to stress to patients, right, is we are going to keep you on oral hormonal therapy for as long as we possibly can before introducing chemotherapy, just given the quality of life issues, right? Given how often they have to come into the clinic, the need for support, the hair loss, like you mentioned. And I think they're so happy to hear that. I think, like you said, a lot of them don't really know what they're gonna be exposed to, right, at the beginning of this disease and diagnosis. So I would agree with you, when in that first line setting for a long time, we went from single agent hormonal therapy to hormonal therapy with CDK4/6 inhibitors. I've had a couple of patients, but only a couple so far that I've identified in that first line setting that qualify with the PIK3CA mutation that you mentioned you're looking for, that qualify for the triplet combination. But, to find patients who meet that criteria, right, that recurred very earlier on the AI with the high-risk disease has been hard. But I am glad that we have something for those patients.
Whenever you had shared that, I was just thinking to myself, look at how complex this is now, right? Look at all this wonder. What a blessing in disguise it is, right? To have all these different studies and to have all these different tests, and knowing that finding those right combinations and how to use all this information wisely is also an art in itself, and something that we need to be really diligent to teach our younger doctors too, to figure out how to best have those conversations.
It's so true. I think that we have all of these drugs, and in some cases we have some sequencing data, right? But the more that comes out, the less sequencing data we have, because we can't keep up the sequencing trials with the rate of new regimens that are coming out. And so I think that's an interesting conversation to have with the patient, which is there's not necessarily one right answer. Often there is, but often there are choices, right? And that's when we look at the individual patient. What are their primary focuses? Quality of life. What side effects are they hoping to avoid? What comorbidities do they have? And it becomes a much longer discussion, right? Very much a shared decision-making with the patient and the physician, which I think in the past we had one or two options and it was a pretty simple conversation.
I wonder too, whenever we talk about precision medicine, we're talking about biomarkers and we're talking about testing tumors. Something I try to stay mindful for in this metastatic setting is I like to also remind myself that if a woman didn't qualify for genetic testing before, I want to stay mindful that when she does become metastatic, that I also look there. And I think it's easy for us to lean a lot on our different platforms that can tell us some of these somatic mutations, right? But I always want to think about, I hope I never forget this one piece because it's not only important for treatment options, but it can also help her family.
Absolutely. Yeah. I'm so glad you brought that up because I do think we think about it more in the early stage setting, right? We look for who qualifies by guidelines. Although I will say, I think now, especially if you've got a patient who may not qualify by certain guidelines, if they would qualify for a PARP inhibitor, say, we're doing genetic testing, I think on a lot more patients, which I think is good, to catch those patients. And it is really important to look back. Did they have genetic testing? And, I find a lot of patients who recurred many years out, they only had BRCA1 and 2. Back in the day. And so I always get that genetic testing report to see, do we now need to do expanded panel testing on them? Because depending on when they were diagnosed, a lot of them didn't have that. So tell me, what are you doing and your colleagues doing in San Antonio? Are you typically, the first time you're doing your genomic testing, are you typically doing liquid biopsies? Are you using tissue if you have it? And how does that change sort of as time goes on and you're doing, multiple genomic testings over time on these patients?
It's controversial too, right? I almost feel that I remember in training, it was tissue is the issue, but we are really leaning into a lot of liquid testing, knowing that we can find in this hormone positive group of women, ESR1 mutations, liquid. And I think that's really exciting. Tissue we are doing more liquid testing with tissue, if of course we have the tissue, knowing that especially in this group of women, tissue testing on a lot of the bone lesions or the bone specimens for this, whenever a woman recurs in her bone-only disease, it's really helped open opportunities. But we've really had a lot of success with our liquid testing.
Agree. Yeah, we have multiple choices now, right? I mean, there's lots of different platforms and companies that you can go with that'll provide the liquid testing. And it's obviously way more convenient for patients. And I think you mentioned the exact scenario when someone has bone-only disease, which is obviously a very common scenario. That's really our go-to. And in certain cases, like you mentioned for ESR1, it's really the preferred test regardless of whether tissue is available. So I would agree with you. If we have tissue, typically sending that when possible, liquid testing, just there are some companies that'll go draw the blood at home for patients. So, it really, I think, becomes more convenient for the patients and easier to track over time when you're going with the same system, time and time again.
I also appreciate deeply not just what you shared with them going out to patients, but I appreciate how a lot of these platforms are staying mindful of financial toxicity and the patient financial assistance that comes with that. And I know we try to stay mindful of that, and we have a lot of systems, if you're lucky enough to have a nurse navigator, and if you're lucky enough to have that social worker. But having that built in for a lot of the companies is, I hold gratitude for, since not every system has the capability for social workers, but every patient should get support in this regard because there's so much more to cancer, such an invisible burden. And so while, yes, we're advancing science and yes, we're finding precision and trying to make better decisions, how can we help offset costs for every single step of this is really important.
It is, like you said, financial toxicity, huge, right? An entire area of research dedicated to financial toxicity. And to take some of that burden kind of brings up the other side of this, which is access to care. You and I have lots of social workers and lots of programs that can help our patients, but depending on where patients are being seen, they may not have that same access. And the worst case scenario would be a patient who turns down the testing because they think they're not going to be able to afford it. And so for the companies to take on some of that responsibility is really wonderful for the patients, especially when patients are in an area where the access to a higher level of care isn't necessarily there.
Earlier in our conversation, you had asked me, when do you like to get this test and when do you like to do it? And I shared with you a couple scenarios where I like to do it quicker than other situations. But another situation and I'd love to hear your thoughts on this as well, when the treatment isn't going the way I think it should. Mm-hmm. When a woman is not responding or she's not getting this duration that I would have anticipated, I often find myself stepping back and saying, now, hold on, let me look again. Should I look at a different lesion? Should I go somewhere new, and maybe if I didn't do tissue before, do it now. It doesn't happen often, but when it does, that's another time that I like to step back and say, okay, let's reset.
Completely agree with you. I think when a patient is either having a mixed response, so we're responding in the bone, progressing in the liver, vice versa, or they've just really rapidly progressed on their current treatment. I always think about, is something different, right? Are they in that 5 to 10% where all of a sudden they were HER2 negative and now they've got some HER2 expression somewhere? And so I agree with you completely. I like to obtain a biopsy at that point to just repeat our basic biomarkers, right? Did the ER and PR go from, all reds of 8 to all reds of 4 and 3? Are we losing a lot of that hormone sensitivity? Do we now have some HER2 positivity? And especially now that it's not just HER2 positive, HER2 negative, right? Now we have HER2 low, HER2 ultra low. So for a patient who was HER2 0 to begin with, and not a candidate necessarily for HER2 if they're not HER2 ultra low, now we can repeat that biopsy. And, I think studies have shown by the time you do 4 or 5 biopsies, absolutely everyone's going to have some HER2 positivity, right?
Yeah.
And so I completely agree. It's a great time when something is just not sitting right. I'll be honest, when someone you can sort of tell they're on the verge of progression. Their scans are just so slightly different. If you're following a tumor marker, maybe that's going up. I will often at that time go ahead and send off a liquid biopsy in anticipation for one of these next set of scans is going to show something. And even though turnaround time on these is decent, it can be 2 to 3 weeks. And, even though medically we know that's not going to impact their care, that's very stressful for patients, right? It can be very distressing. And so I think preemptively ordering that when you really feel like you're getting close is another one of those scenarios.
Which now feels like a natural segue into triple negative disease.
Perfect.
It's exactly the cancer type when a woman is metastatic, and really feel like we have a lot of movement with precision when it came to estrogen, finding these different resistance markers. But I was thrilled at, what was it, back in 2017 or 2018, whenever we first started talking about the very first one, PD-L1, right? Like looking at PD-L1 and now looking at CPS scores and knowing that we may not need these initially, right, for triple negative breast cancer, but it's still, I think, helpful, or I like personally to have them. Also, because I feel like it plays a big role too in patient education, which making sure our patients are informed and feel that they not only understand where these treatment recommendations are coming from, but why they're coming from it and where they stand and what we could maybe anticipate in the future and how this roadmap looks.
Yeah, it's very true. A lot of patients come in saying, can I get immunotherapy? Do I qualify for immunotherapy? And having that conversation these days is a lot easier, right? Because we have very specific markers that we're looking for on the genomic testing that tells us if they're a candidate for immunotherapy or not. And so, whether they've got PD-L1 positivity in the triple negative disease, whether or not they've got high TMB, right? Regardless of biomarker status, we've got a lot more options than I think we used to. And of course, that brings in a lot more toxicity and a lot more side effect managing that we're having to do for these patients. And, again, it just highlights in metastatic disease, having your options, knowing what the tumor mutational burden is, knowing what the different somatic mutations are, allows you to help pick the therapy that not only ideally is going to be the most effective for them, but gives some context for what types of side effects they might experience. And then again, helps in that shared decision making.
In triple negative breast cancer, in the metastatic setting, biomarkers being so important and for us to be precise to give the best recommendations for treatment. But again, it reminds us about that germline testing again, where looking at our patient's actual DNA and how can that potentially play into the treatment options. And to me, well, maybe having a BRCA mutation or a similar DNA misrepair mutation, and while it itself is not a biomarker, it's precision. And I'm glad that we can still offer drugs like olaparib in this setting as well.
Yes, completely agree. And I've found at least one I know of, and I think probably many more at this point, of the platforms, you can actually get your germline testing right when you're ordering your genomic testing. So it's making it a lot easier for those patients who didn't have it. And, I think everyone listening here knows the difference between genetic and genomic testing. But, there are some patients, I think, who might be listening, and it is important, I think, to point out the difference. Patients will often say, well, I had the genetic testing, right? And to explain the difference between the hereditary germline testing we're doing, looking to see if they're a candidate, right, for olaparib or other things, versus the genomic testing where we're actually looking at the tumor DNA, is an important difference, and one I find myself going over a lot with patients in clinic.
Earlier, we were just knowing that there's also patients listening, not just providers. But when we're talking about precision medicine and we're talking about this rapid advancement, and yes, we're getting kind of less information as we get more because, well, they just came out and we're still collecting that information. I think this is a good moment to reminding others that this is also the space for clinical trials. And when we're talking about precision, right, and we're talking about testing, remembering that clinical trials, what a misnomer, because to me it feels like it's like an experiment, but it's meant to enhance and make somebody's life better. It's not meant, you're not a lab rat. It's no, we have this therapy and we're adding it to something to make it better. How do you like to tell your patients? That's what I've been trying to share.
Yeah, no, I think that's great language. And again, because I think there are some misunderstandings, there are a lot of clinical trials in the field of medicine that involve a placebo, right? We're going to treat you or we're going to give you a placebo. And when patients come in, and some of them have that thought, well, I don't want to get randomized to nothing. And I have to tell them, no way would that ever be the case. In fact, for most of our phase 2 or phase 3 trials, I tell them you're either going to get what I think is the best treatment for you anyways, or you're going to get something that we think, whether it's added to that or in place of that we think has the potential to actually be more effective. And so I do think that is a really important thing to talk about with patients. And I think it goes to making sure you're asking patients where their hesitancies come from, right? There are some patients who say, I will not do chemo or I will not do IV, finding out why, because sometimes it's an experience of a family member who had a different cancer with a different treatment, and then just being able to educate them so they can make those educated decisions. And I think when they get that information, that you and I were discussing about how to present it, that a lot of patients are more open to clinical trials. And I think the other thing is, despite the advancements that we've made, especially in triple negative metastatic breast cancer, there is still so much room for improvement.
So much
room.
So
we have these great survival rates now in HER2 positive disease and even in ER positive, HER2 negative, but we still need to make a lot of advances in triple negative. And so it's a good reminder, I think, for providers that when a clinical trial is an option for a patient with metastatic triple negative breast cancer, often that is the best way to go. And now we have so many mutation-specific trials. So another reason, right? Get that genomic testing from the get-go before they're started on first-line treatment, so they're not excluded from any potential, mutation-specific first-line trials.
Well said. And we can look at the data that was released just this last ASCO and seeing how impactful that exact message is. So now it's new standards of care, and we've got so many different wonderful places that biomarkers are taking us. Even in so while we're talking so much about this metastatic setting and of course, nodding to clinical trials and why this is actually a lot harder of a conversation because these clinical trials are just coming out. We're getting all this data, we're trying to figure it all
Right.
out. But, in the early stage curable cancers, when we're talking to women with triple negative breast cancer that are getting immunotherapy, but we don't necessarily need that biomarker. Like the flip side of trying to explain, like, look, we need it here in this space, but at least in this regard, we don't actually need to know the biomarker, right? We know that there's more value in giving it to all women, and so it's that how to have those conversations between the two whenever they want to know. That's sometimes what I struggle with in my office.
Absolutely. I mean, we have, 15, 20 minutes usually for follow-up visits. We probably could use 45 for most of them. There's so much information to share, and patients have the opportunity to be so much more educated these days. There's so much more information that they can access. And so I think there is a lot more of this educating. Why am I not a candidate for this? Why are we not talking about this? And oftentimes it's a quick response, right? Well, you're not PD-L1 positive in this setting, and in this setting we require it. But it's so true that there's a lot more that certainly now than when I was in fellowship in San Antonio that we're having to review and go over with the patient.
Whenever I think about precision medicine and we're talking about biomarkers, and I want to, of course, give a nod to the women that are getting cured. And even though we don't necessarily need some of these to make decisions or to give these drug therapies, I like to always remind the women who are getting neoadjuvant therapy. And neoadjuvant, right, that is a game changer for not just our HER2 positive and our triple negative, but seeing it now in even some of our ER positive cancer spaces. We'll get some of that data right this ASCO. But knowing that, hey, there are ways that we can lean into precision medicine based on if you had pathologic complete response, and how we can navigate what we do on the back end for you based on that, which to me, well, maybe not necessarily a quote biomarker, is still precision. That's still helping tailor therapy.
Yeah. And now I'll take the opportunity to make the segue now, because that's a great segue into early stage disease, right? With patients that we're treating with neoadjuvant therapy when they get the path CR. And this is interesting because it ties into what we talked about in terms of getting so many more drugs and so many more regimens without sequencing data and without combination data. So let's say we have a triple negative patient who is treated neoadjuvantly with Keynote 522, and they've got residual disease. So per Keynote 522, we continue the pembrolizumab, but then we've also got the CREATE-X data with capecitabine. And should they qualify for olaparib, we've got that. So tell me, what are you doing for these patients? How are you combining? When are you combining these agents?
That's a really good question. So there is safety data with Xeloda or capecitabine partnered with pembrolizumab. And so I do my best to try to get insurance to approve, right, is for my patients that do not have a BRCA mutation. And if we did not get pathologic complete response, then after their radiation, while they're on pembrolizumab, I do offer Xeloda for these patients. And I try my best to get that approved and combined with our pembrolizumab, knowing that there is safety data, knowing that lots of patients can tolerate that. But I will say that it is a tough drug for some women to handle, and always staying mindful of, okay, well, what is this benefit, right? What % are we trying to gather here? And if we're thinking about, 1 or 3, versus 15, 20, right? I don't necessarily push as hard to have somebody stay on something that I think is causing more harm than good, when, as I try to share with her, I don't know which woman's cancer could or will come back. I only have tools for us to do together to try as much as we can to prevent it. But if that tool is hurting you, or if this is causing so much harm, then that's not the right decision for any of us.
Right. And that brings me to something I tell patients a lot, which is no decision is permanent, indefinite, irreversible, right? So we can try this combination, and we may have to dose reduce the capecitabine. We may have to drop it at some point, but we can always do that, right? So you're not going to suffer for 6 months or 12 months, depending on the dosing they've chosen, that we can always adjust, And I think that that's really important to bring up as well, especially in the patients who are hesitant for these therapies. I really tried to push, let's at least try it. Let's try to give you the best chance possible. If we can't do it, then we know we tried.
Well said. And when it comes to a patient with a BRCA mutation, I work very hard with her. She and I will do everything in our power to try to use that olaparib or talazoparib therapy if she does not have pathologic complete response. I think the data is very good. It's very clear here. And I find that women tolerate this medication fairly well I don't want to jinx myself now, but I find that the nausea is fairly tolerable, the diarrhea is fairly tolerable, but making sure to give this opportunity for BRCA patients is really impactful.
Absolutely. Yeah. Again, precision medicine, right? Every patient who doesn't have a path CR isn't the same, right? Some are going to be pembro potentially only, depending on how much residual disease they have, right? Are they RCB1, 2, 3? Some were combining with capecitabine, some with olaparib. So there's quite a spectrum there. And then we have obviously the patients who do have a path CR. And for those patients in that moment, that obviously confers a great prognosis. Standard is still to continue, right, and complete the 1-year pembrolizumab. Do you have the Optimize trial open there that randomizes patients with a path CR to either complete the pembro versus no pembro?
We do not have that trial. We have no, we don't have this one.
Okay. Other options though for patients who have achieved path CR?
We are really leaning into with our patient population, a majority being a minority high-risk group of women, being Hispanic here in San Antonio and South Texas, we have really wanted to align we are just opening, we had our SIV today for a triple negative where if we didn't have the pathologic complete response, adding an additional agent with pembro. So
nice.
Our site is really looking for additive for our higher risk cohort or group of women to serve our community. But I think the de-escalation trials are so important too. Is that open at your site?
It is open. And, it's interesting that there's a lot of trials where I could say something similar about where you're explaining to patients the rationale, right? You have this excellent prognosis with a path CR, so we think we can get away without it. And then you have the patient say, well, then why would I take it? Right? Why would I take it if you're telling me it's probably okay not to? And then, so you have to go into the whole difference, right? Between, what retrospective data can tell us versus randomized prospective data. And I will say you run the risk of someone choosing what's not standard of care off of trial, right? So I've had patients for whom we've had this discussion. The plan was to go on the trial. And then they just said, you know what? I've made my own decision. I'm not going to do the adjuvant therapy. And of course, that makes us nervous, right? Because doing it outside the context of a clinical trial, harder to get that answer for everyone. Totally different subject. But I find the offset trial is very similar.
Yes,
right?
Yes. You got me jumping up there because So for some of our listeners, and the offset clinical trial is looking at women. They're within, Taylor RX and RX Sponder. There's that group of women that we still have that question mark if between this age group, if she actually needs the chemotherapy or if it's just the ovarian suppression. And that's what offset is trying to tease out. And in this vein, right, you're telling women that we have every reason to believe that with this number and with your presentation that that you are a woman, that we don't think it's the chemotherapy. We do believe it's the ovarian suppression, and that's why we want to randomize you to the two. But I understand the fear, and I have had more patients decline than enroll. I would say 75% usually decline, 25% enroll, because it when you're sitting with that decision of, if this comes back, would I regret not having done this one thing, knowing that I'll never know either. As a physician, I won't be able to tell you. As a patient, you won't know. But that is where I find and that the hesitation and that comes from. And It has been
Absolutely.
challenging. Yeah, it's been challenging.
Yeah. And it's completely understandable. I mean, I think your 75-25 split's actually pretty good compared to some of our experience. I mean, you explain the trial so well, you explain the background data, and then you, in my experience, you have one of two scenarios. You have a patient who says, well, if you can't tell me definitively there's no benefit, then I want the chemo, which is completely understandable. Then you have the patient that says, you've convinced me so well with some of the available data that we have, even though you're telling me it's not definitive, I think I'd rather forego the chemo. You find that patients ultimately want to make their own choice in that setting, which again is the same thing as the path CR and triple negative we're running into. It's very hard to answer these questions because we're asking a lot of patients. We're asking a lot of them to enroll in these trials, but at the same time, without this data, we risk over or under treating a massive amount of patients.
Which I don't know if you're comfortable comparing these two, but it kind of makes me think of even some of this other new data that we get, such as like Destiny-05. And when we're talking about not having pathologic complete response in HER2 positive patients, right? And starting to triage one who doesn't have pathologic complete response and knowing that we're tailoring therapy, which is precision, but then two, risk stratifying that group, which is already high risk, but even further risk stratifying is, I find, also a challenge too for our practice or our group.
It is, absolutely, because still at the end of the day, and I just had a patient talk to me about this yesterday. They said, so what you're telling me is this is for prevention. And yes, it is, right? I said, we're trying to put the odds in your favor. There's no guarantees either way. So at the end of the day, to convince someone to take something for, quote, prevention. Now, I think it's an easier sell in certain situations, right? We're talking about residual disease and HER2 positive versus perhaps a node negative, ER positive, 5-centimeter tumor with endocrine therapy. Some of those are harder sells for patients, but it is very difficult to know because at the end of the day, people like to talk about trastuzumab deruxtecan as a chemo-free regimen. Doesn't mean it's side effect free, right? Some patients tolerate it remarkably well and can stay on it for very long periods of time, but some patients have a really hard time with it. So we're constantly balancing the escalating, de-escalating. And I do think in residual disease, HER2 positive, triple negative, that's exactly where we do need to be escalating, right? We've got to find something for these patients. And I think the exciting thing about the trastuzumab deruxtecan potentially in that setting is the hope that we're actually going to prevent some of these CNS recurrences, right? Because there's nothing more devastating than a path CR, whether it's triple negative or HER2 positive, who 18 months later has an isolated CNS recurrence.
Well, I know you're the one that's leading this podcast, but I want to know, Dr. Peterson, when you have a triple positive, how much do you push Neratinib?
Yeah. So I will be honest, I do discuss this in detail with patients. I think it was a harder sell earlier on when we didn't have as much follow-up, when we didn't have the survival data. It's tricky now because so much of our patients get neoadjuvant therapy, right? And so those we don't have that hard data to describe to those patients what the benefit is. But I really think about these CNS recurrences all the time. And especially now, thankfully, they did the trial, right, with the escalation of the antidiarrheals. And I find between that and dose escalating the Neratinib itself, it's much more tolerable. You know, God forbid we give somebody full dose and no antidiarrheal, that patient's going to come off of it within 1 to 3 weeks, right?
Certainly.
Yeah. So I have come around to that. And I do have an in-depth discussion with patients because even though it's a really small benefit, it's a benefit for CNS, right? That we don't, as of right now, have a lot of other great options for. So I think it was a harder sell in the past, but I think I push it a little more. Still always the patient's, decision, but that longer follow-up data and now the fact that I think it's better tolerated the way we administer it, I do discuss it with everyone.
I'm so glad to hear that we share a similar view on this, but also it sounds like it's us empowering our patients, and it takes us also having to hold on this level of precision, right? And we're trying to explain, I don't want you to live your life in fear because you have done everything in your power to be cancer-free, and I'm doing everything in my power to give you opportunities so we can stay cancer-free. And trying to prevent brain metastases or recurrence with a brain lesion is is something that I know I personally carry, that I share with patients, but I don't want them to live their life in fear of it. But at the same time, I think that it's part of how the conversation is the successful use for Neratinib, saying that, look, this is one way that we can't, there's a lot in our futures we can't control, but that which we can, and that which we can try to do. And so I also have that conversation a lot with my patients with the triple positives because of brain mets.
Yeah, I agree. And again, these are things that evolve over time, right? I think when it first came out, there was very, very little use. And I think as we've gotten longer term follow-up data, it's something that's becoming, I still think there are people who don't push it. I certainly think that's the case. But I think, you've got to pay attention to that longer term follow-up data so we can give patients, the most updated information.
We were talking about neoadjuvant therapy, and we were talking about triple negative and HER2 positive, but this is going to sound a little bit controversial, but an ER positive, especially in our premenopausal patients and those, of course, that have a node. I say, of course, like everybody on this call or this podcast would know, but it is so important to know. I like to know what their Oncotype or MammaPrint is, and kind of depending on if she's a premenopausal woman or a postmenopausal woman, sometime, and how big this is, kind of impacts which choice I make for this test. And I would say that I think partly clinical trial driven, but I find value in both tests, knowing that we have options in this space.
I think that is such an interesting point that you make, and very difficult clinical decision, right? Because we know that these tests aren't always in agreement. Probably in the last 3 months, I had a patient who had each test ordered by a different provider and came to me with a second opinion, with a MammaPrint saying chemo and an Oncotype saying no chemo. And that, again, is a very difficult, not only clinical decision, but discussion with the patient. And we have right now, the SWOG trial open here, the 2206 for high risk neo. Do you guys have this as well?
We sure do.
Yes. So I would say there is a totally different reason that's been difficult to enroll, and it's mainly been getting the MammaPrint in a timely fashion, and not making patients wait, 3-4 weeks before we have that and can sort of move on to the second step of registration. But I think that is a great trial for patients, right? That's an example of using a genomic assay in the neoadjuvant setting to help predict who's going to respond to neoadjuvant therapy. And then on top of that, hopefully potentially find a group within the ER positive space that could benefit from adding immunotherapy to their neoadjuvant disease.
I find it was so inspiring and practice changing whenever all of this came out, just from the get-go, right? Being able to empower women to have a level of confidence for us to say, look, we have data that suggests that you don't need chemo for this estrogen positive cancer. We know, my goodness, we see the estrogen on the outside of the tumor. We know a lot of this is driven by estrogen, and being able to better triage and help women see who needs chemo and who does, or who may benefit from chemo, who would potentially benefit more from chemo than others. What is now also, right, we're also facing is, okay, I have this great test that can tell me sometimes, hey, this test that we have together suggests that you don't need chemo. But then when I look at these other variables, how many nodes she has and the gray, all this other stuff, and but by the way, we really need to talk about dual therapy and this adjuvant and the hormonal side. And I appreciate that these platforms, which help us deliver precision medicine, that these platforms, irregardless of who we're talking about, they help us share, explain, patient educate that there are two different processes, especially when we think about the estrogen positive tumors and the burden and how we should look at the treatment and prevention, which I find helpful as I'm discussing hormonal therapy, because it allows me to lean into the reversible risk factors like diet and obesity, and discussing bone health or prophylactic use of bone agents. I found benefit to that in my practice.
Absolutely. Yes. Don't get me started on diet and obesity and exercise. We could stay here for 2 more hours, but yeah, it's such an important aspect to all of this. One thing I was thinking about when you were talking about this population is we've got the CDK4/6 inhibitors now, but most of those trials were designed off of anatomic staging, right? What's your tumor size and what's your nodal status? Well, what about the patient who doesn't qualify by those, but has an oncotype of 45, right? So we have these challenges where it sometimes seems to make sense to use something, but we don't necessarily have the data to use it. So I think that's actually a very sort of focused area where more precision medicine is needed, right? Bring our genomic assays into some of these so we can go beyond just the anatomic staging and how we're triaging these patients.
Well said. Well said.
Well, I don't know how we covered like metastatic and early stage, and I think all biomarker subtypes to some degree, but we did. We've got a few minutes left. Is there anything we didn't talk about that you wanted to be sure to cover, or any message, I think you want to leave providers with in terms of, things to always remember? I think that you made a great point about the genetic testing, right? Always look to see if they've had that and see if they've had panel testing. Are there other pearls or things you really want to make sure that we discuss?
There are two topics that when we talk about prevention, I feel so passionate about, and I know we touched on it earlier, but one is clinical trials and helping advance science, because we have so many questions in regards to precision. And clinical trials we often think about our large academic institutions, and you and I both coming from these larger academic institutions and knowing that lots of opportunities can still exist, I believe, in community practice when it comes to some of these trials, especially as it comes in the adjuvant setting. And I'm hopeful that patients are being offered clinical trials, or that they understand, or that we are doing our due diligence to explain well in oncology that these drug trials, you are not getting a placebo, right? Like this is not an experiment on your life. We would never question or try to shorten your life. We will only offer you therapies that we know are already good for a lot of our phase 2, phase 3s. It's the addition of something else. And
Absolutely.
Changing the rhetoric around that and building trust again within our communities, knowing that there's a lot we will not understand, because patients there's cultural, there's lots of history. There's a lot of different variables that we're not going to be able to fix overnight, but the dignity and the respect and the conversations and speaking at a patient with their level and reassuring and letting them know that we have their safety in mind, and that's clinical trials are the advancement. I hope that anybody on this call if they haven't started a trial at their practice, or if it's been a long day and God, that's that extra 5 minutes to try to talk to that patient about it, we'll get that energy come to up deep. I would love to share that. But the second is exactly what you and I said we probably shouldn't talk about, because it's going to take 2 hours more, is the power in the mindset for wellness. And I use these words intentionally because we're not talking about an illness that we're prescribing a medicine for. Instead, it is speaking to a patient through the lens of, you have done everything you can to be cancer-free. We are doing all of these things, including whatever medicines we may be prescribing. But in addition to that, there are other ways. I cannot tell you the percent. I cannot tell you how much. I only know it will if we do X, Y, Z. And no, that's not going to be an ICD-10. And no, that's not going to be reimbursed. But they will listen to us. And I have seen truly meaningful changes. And it really has made me question even my own scope of, well, should I be prescribing more GLP-1s looking at some of this data? I mean, we used to say, I'm only going to let some of these other fields of medicine do it. But if I know it can prevent, or if it's showing more and more signs of reducing risk of recurrence, or we're trying to reverse the obesity, or we're doing the insulin resistance, you know what? Maybe I will start prescribing some of these too. And that's my last point is the nutrition and the fitness, it is like a vital sign. It is something absolutely in our scope. And it's really important for making sure, or giving our patients every opportunity for cancer not to come back.
I appreciate that so much. I could not agree more, with everything that you're bringing up there. I do think, to your point, it's difficult sometimes for physicians to provide this counseling in the clinic. either they're not as familiar with the data, right? Because it is a very different, area of research, but also because there's not the time, or I think in some cases they feel nervous to bring these things up. I'm treating this patient for cancer. Should I really be harping on them about their weight or something along those lines? We've recently started a separate clinic where we see newly diagnosed patients and they get both a visit with a nutritionist and a physical therapist, and we go over the cancer survivor guidelines with them. We find out what they're doing. We try to bridge that gap for them. And they also meet with a medical provider to go through all of their social, emotional, financial needs. And so we've tried to take some of that burden off of the providers in the primary oncology clinic. And it also creates a space to go over clinical trials and talk about genetic testing. And so there's only so much you can do, right, in clinic. And we try to do it all. We really do, because we want to do it all for our patients and avoid extra visits. But one thing I found is when you try to do it all, sometimes it gets thrown in at the very end, one or two sentences like an afterthought, which I think for lifestyle can actually be detrimental. Because then the patient thinks, well, you said it in 30 seconds at the end, so it must not be that important. For me, it's almost better to let someone else have that conversation or have a separate visit for it, because you don't want patients to think, oh, well, they just said it in 30 seconds when they talked about these other things for 30 minutes. So probably not that important.
What you shared about developing that new system to give an extra provider that's focus is, it sounds like prevention, right? Prevention, we're thinking about like primary care. We too have integrated our primary care in our cancer center to have these very similar conversations, because like you said, we can't do it all. But I think we're all mindful of it for our patients, and knowing that both of our institutions are making an effort for this, because I don't want anybody listening to this podcast to think that the world is on our shoulders, because you're right, we cannot carry it all.
Right.
But what opportunities, if not in our own systems and in your system, to whoever may be listening, what opportunities exist to plug your patients into? Is it your primary care service line that is really owning and pushing maybe obesity and managing weight loss clinics? Or is it your endocrine? Or if you're in a private practice setting, is there that person down the street that opened up this one practice? Is that an opportunity for your collaboration? I wonder, I'm just grateful that we're having more conversations about exercise and about diet for our patients, even if it's not necessarily our main focus.
Right.
The collaborations and the partnerships we're building, we really are changing the face and the medical structure from what it used to look like.
We are. And I think you left that with some really practical points, right? So you don't have to be at a cancer center that has these separate clinics to go to. It might take a little legwork to find out who those partners can be to deliver this information to your patients. But whether you have that or whether you carve out 5 minutes at the end of the visit, give the patients resources, right? We've got the AICR, we've got NCCN with patient survivorship facing guidelines. We have so many different things that patients can access. And so if you've got the dedicated service, fantastic. If you don't, try to make it. If you can't, provide the resources.
And patient advocacy groups, because only every patient's being able to talk to other patients. That is so powerful. And also opportunities outside of that. That's also areas where they talk about wellness, they talk about diet, and they talk about nutrition.
Absolutely. Those support groups, oftentimes they'll have, speakers come in, right? And they can talk about different things. There's so many opportunities. Like I said, we could have another entire, discussion about this. We'll have to schedule that for next time.
We'll do it later, Lindsay.
We'll have to do that later.
At the 47th annual SABCS this 2026.
There you go. Sit down. That would be wonderful. Well, it was so great talking with you, meeting you virtually, and hopefully we'll meet in person at either ASCO or SABCS. It sounds like there's a lot in common we could sit down and chat about.
Wonderful. Well, thank you, Lindsay. This was just an honor to be on this podcast, and such a delight to speak with you, knowing all the wonderful work that you've done for for our scientific community. And I mean, maybe a lot of people on this podcast don't know about all the contributions that a lot of it is from your work too. So thank you for inviting me.
Well, thank you. It's been a pleasure, and thank everyone else for joining us talking about precision medicine and breast cancer on the BackTable Podcast.
thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.